Welcome to Neuro Frontiers, a series in which practical neurology partners with ReachMD to discuss topics at the forefront of clinical research and advancements that further clinicians' ability to diagnose and treat neurologic conditions. In this episode, Riley Bove, MD, Associate Professor, UCSF School of Medicine, discusses results from two studies examining Ocrevus treatment in pregnant and breastfeeding mothers with multiple sclerosis.
Hi, I'm Joe Rusco, the editor-in-chief of Practical Neurology, and it's my pleasure to speak with
Dr. Bove today
about some research presented at the ECTRIMS 2024 conference. Dr. Bove, please tell us a little bit about yourself.
So my name is Riley Bove. I'm an associate professor of neurology at the University of California, San Francisco. I'm an MS neurologist, and I see patients across sort of the adult lifespan, advising them on concerns relating to pregnancy, menopause, and providing comprehensive neurological care in the clinic.
And you were recently involved in the ECTRIMS 2024 conference with two specific studies in MS, the MINORE and the SOPRANINO studies. If you could briefly explain the purpose of the MINORE study and what was being measured in that trial.
Yeah, so this was really an exciting time for us in the field of sort of pregnancy and MS to be able to bring these two studies to kind of result phase and share them with the neurological community. So we have known for some time that people with MS have a high risk of relapsing and having new brain injury, nervous system and injury after pregnancy. And the field has really been showing that starting highly effective therapies early postpartum and even before someone even becomes pregnant is associated with really good MS disease control throughout the pregnancy course from pre-pregnancy to postpartum. And so these two studies were designed to assess the safety of ocrelizumab and to understand whether ocrelizumab crosses the placenta and affects the baby, and whether ocrelizumab crosses into breast milk and affects the baby. That was the SOPRANINO study. So to get to your question about the MINORE study, the real goal of the study was to understand placental transfer of ocrelizumab from mothers with MS to the babies and to understand potential effects on B cells. This is the first pharma-sponsored prospective phase 4 study of this kind.
Excellent, thank you. What were the results of the MINORE study?
So in the MINORE study, we enrolled pregnant women with MS during the second trimester, and we followed them throughout the rest of their pregnancy. And we had kind of two key time points. The first was looking at maternal and cord blood levels of ocrelizumab at birth. And then the other key time point was looking at maternal and infant ocrelizumab levels at 6 weeks of life. And when we looked at our first key endpoint, so the proportion of babies who at 6 weeks of life had B cell levels below the lower limit of normal, none of them did. So none of the infants potentially exposed to ocrelizumab during pregnancy because of maternal treatment around pregnancy, none of those babies had B cell levels below the limit of normal at 6 weeks of life. We also looked at other outcomes as well. We found that ocrelizumab was undetectable in most mothers at delivery and in the umbilical cord blood from most infants. So in 94% of infants, it was undetectable. But in 2 infants, there were very, very low levels of ocrelizumab in cord blood, close to the lower limit of detection. Finally, we didn't have any kind of new safety signals in terms of infections.
Excellent. Thank you. So what are the implications of these results in terms of how it affects clinicians?
To take a step back from the study findings and sort of like how this fits into what we know, we do know that immunoglobulin G, IgG levels start crossing the placenta around week 20 of pregnancy, 18 to 20. So we know that in general, if someone were given an IgG monoclonal antibody before they became pregnant, by week 18, 20, when that drug could start crossing the placenta, we know that theoretically it shouldn't. What this study shows is just it provides more definitive answers about a specific medication. So the results of the study are not surprising in the sense that ocrelizumab IgG is going to behave like other sort of endogenous IgGs in the mother, but they do arm physicians with evidence specifically relating to this product. And it's very helpful in terms of being able to communicate the safety of the medication with pregnant people and their families. And it's also really reassuring to know that the babies have normal B cells.
Excellent. Thanks for putting that into context. So you mentioned the SOPRANINO study and what was being measured. What were the results from that study?
Yeah, so the SOPRANINO study was then tackling the question of transfer of ocrelizumab. So after delivery, baby's born, mother resumes treatment. We know that that treatment is going to be highly effective at stabilizing her MS course postpartum. And we know that many of our patients want to breastfeed and that breastfeeding has general benefits for mother, general benefits for baby, and also can reduce the risk of relapses in the mother. So in that setting, the question was, so if the mother wants to breastfeed and restart her therapy, does that drug cross into breast milk? And so in this study, what we did is we enrolled women with MS after delivery. And the decision about whether or not to breastfeed and whether or not to get Ocrevus was made between the mother and their treating neurologist. And we enrolled them if they received ocrelizumab before week 24 of the baby's life. And we followed, so we enrolled women who received ocrelizumab within 2 to 24 weeks after the baby's birth. We started at 2 weeks because before that, the breast milk is not as mature. So we have the colostrum phase and the sort of transition phase. And we kind of wanted to leave that phase alone. We really wanted to start looking at women who were treated starting at 2 weeks when the breast milk is mature and up to 24 weeks. And we followed both the mothers with serial breast milk collection and the babies. And the key time point for the babies was looking at their blood about 30 days after maternal treatment. And so what we found was that all the babies were healthy. If you followed the ocrelizumab from maternal infusion, getting into maternal bloodstream, and then measured the ocrelizumab content of the mother's breast milk, the ocrelizumab levels in the breast milk were negligible. So the average daily infant dose in the baby was 45 micrograms compared to the 300 milligrams or 600 milligrams that mothers get with their infusions. And then if you followed the ocrelizumab, so the levels are negligible in the breast milk, but then now they have to go into the baby's GI tract, be absorbed into the baby's bloodstream. And if you measured ocrelizumab in the baby's blood in the infant serum, ocrelizumab was undetectable in the infant serum. So to summarize that again, a very tiny, minute amount of ocrelizumab got into the mother's breast milk, but none of that got into the baby's bloodstream. And furthermore, all the babies had normal B cells 30 days after maternal infusion. Just other study results were that the infections were sort of typical infections of childhood. Most were mild or moderate, resolved. We didn't have any new safety signal. And the final kind of pieces in the study are continuing to follow those babies out fully through 1 year of life, just being able to report fully on their growth and development and the maternal MS outcomes as well. Just to note, so far, there have been no relapses.
Excellent. Thank you. And as with the MINORE study, what are the implications of this in terms of practice? So it sounds very safe. You can trust it in this patient population. So good news that confirms existing data out there.
So again, to put these findings in context, we have also known that most of the antibodies, most of the immunology that is transferred from mother to baby through breast milk is really IgA. Because patients ask me a lot, am I not supposed to have antibodies in my breast milk? So why is this not getting through? So most of the sort of the immunity that mothers give their babies through breast milk is IgA. We know that a little bit of IgG crosses in general, and most of that is sort of just not absorbed by the baby. These findings are consistent with what we know about physiologic IgG transfer. They're also consistent with a large body of independent investigator research from our group and groups in Scandinavia and Germany that have also found very low transfer of the product into breast milk. Being able to confirm that there was no ocrelizumab in the babies, I think, is a really important kind of step here that just really provides reassurance in clinical practice. That said, we have to acknowledge that neurologists were a little bit behind the times when it comes to reproductive health and safety. A lot of the other organizations, the rheumatologists, the gastroenterologists, have for some time said that IgG monoclonals are okay to give during lactation. We're just a little bit behind the times and doing the research and also asking that pharma do these important studies. And so I think it was really wonderful that we were able to do this research and to have such definitive answers. One other point to just note about clinical context is these were really in people who had been on ocrelizumab for just a few years. We still have a little bit of work to do to understand what about people who have been B cell depleted long-term for 5, 10 longer years.
Any final thoughts about either study that you'd like to share?
As someone who's been really working hard and advocating in this space, I'm really delighted to see the progress that has been made. I'm really delighted to see how many physicians think this is an important question, how many scientists think this is an important question, and how the drug companies that make these products for a condition that predominantly affects females of childbearing potential are really starting to answer questions that are important to their patient population. So I think this is really just part of a very exciting time in women's neurology and being able to provide evidence basis for all of our patients.
Excellent. That's a great point. Thank you for that.
Thanks to Dr. Bove for sharing her knowledge with our listeners in this episode of Neuro Frontiers. And thanks to you, our listeners. Be sure to visit practicalneurology.com for more podcasts in the field of neurology.